We will proceed with the second session on hemophilia, that is management of the common bleeding manifestations of hemophilia. So for the comprehensive, whenever we talk about the care for hemophilia, it is comprehensive care. First and foremost is the prevention of bleeding and joint damage. So that is in children, we will be focusing on prophylactic therapy aimed at prevention of bleeding. And once the bleeding has occurred, the next aim is to promptly manage the bleeding episodes, including hemostatic therapy and physiotherapy and rehabilitation to maintain the joint health. Next is the pain management in hemophilia. Then management of musculoskeletal complications, which we have already covered. Prevention and management of inhibitors. Then management of comorbidities in hemophilia. Dental care. Then maintaining the quality of life and patient education and support. So these are the main components in the management of hemophilia. First and foremost important is the patient education. We should always make them aware that physical activity is very important for them to maintain both the muscle and joint health. So they should always engage in non-contact sports like walking, swimming, jogging, cycling. But in cycling, when we do cycling and all, they should be careful to avoid a fall or trauma. Then small ball games like table tennis, etc. And they should be discouraged from playing games like cricket, football, etc. In which there's a chance that the ball will hit their head and cause a intracranial bleed. Coming to the evolution of modern treatment in hemophilia, previously it was whatever was used was the fresh frozen plasma, cryoprecipitate before the advent of the clotting factor concentrates. So towards the end of 1960s, the plasma-derived clotting factor concentrates were available for treatment. So for several years, this was the product which was mainly used for the treatment, which is exposed to several viral inactivation steps. And subsequently, the next generation product, that is the recombinant clotting factors, were available for factor 8 and factor 9 and factor 7A in the 90s. And next is these molecules were subjected to several molecular modifications, like some of the domains can be deleted, some of the this can be pegylated, and several fusion proteins can be created. All these help in prolonging the half-life of the existing product. So that is what we call the EHL product, or the extended half-life product. Now there are several investigational therapies like gene therapy, then novel antibodies like monoclonal antibodies like the emicizumab, which is commonly now started for the prophylaxis of hemophilic patients with inhibitor, especially in children. So these are the newer therapies. The plasma-derived clotting factor concentrate, or CFC, is divided into the standard half-life, or a SHL product, or the EHL product, that is the extended half-life product. Whatever we are using is the standard half-life product. Next is the recombinant products, then bypassing agents, and other non-factor therapies like DDAVP and fibrinolytic agents. Then if none of the above are available, you can use the fresh frozen plasma and cryoprecipitate. Actually, in terms of efficacy, there is no special difference between the recombinant products or plasma-derived clotting factor products. So the plasma-derived products and the recombinant products have proven to have similar clinical efficacy. And regarding the inhibitor formation also, both of these have almost similar incidence of inhibitors. So before going to factor therapy, we should be clear. We should have a clear idea about what is 1 unit of factor rate, because in all our therapies we will give the factor in terms of units. So 1 unit of factor rate is the level of factor rate content in 1 ml of plasma, which is regarded as 100%. So when you take the various blood products like whole blood, the volume will be 450 ml and the content will be 250 international units of factor rate. If you take fresh frozen plasma, the volume will be 225 ml and the content will be 225 units of factor rate. That is 1 ml contains 1 unit. Then cryoprecipitate has the least volume, that is 30 to 40 ml, and the factor rate content will be 80 to 100 units. So this formula is very important for calculating the factor 8 dose and factor 9 dose, because whenever the patient is coming to a casualty, we'll be using this formula to calculate the factor dose. For factor 8, the formula is body weight of the patient into desired factor level into 0.5. For factor 9, it is body weight into the desired factor level. So this formula we have to know by heart. We are following the WFH guidelines for giving as a guideline to what factor level should be maintained for each of these bleeds. And according to WFH, there are two practice patterns. That is low dose practice pattern for resource constrained countries and high dose practice pattern for the developed countries. So we will be following the low dose practice pattern for most of the indications. Now coming to the factor concentrates. Before proceeding with the treatment of individual bleeds, we will deal with the factor concentrates. So factor 8 concentrates are usually available in product strength varying from 250 IU to 3000 units per vial. In here, we usually use strength starting from 250 IU, then 500 IU, 1000 IU, etc. And on the top of the factor product, the vial strength will be printed on the top of the factor product. Depending upon the batch, the product strength will vary. So always when you are using a factor product, first check on the label what is the strength of the product. So in the absence of any inhibitor, each unit of plasma derived or recombinant standard half-life factor rate product used per kilogram of body weight will raise the plasma factor 8 level by approximately 2 units per deciliter. And hence, from this fact, this formula is derived. That is, for calculating the factor dose, you have to multiply the body weight into desired factor level into 0.5. The half-life of factor 8 is approximately 12 hours. So that is why we are using it twice daily. So we will give one example, that is to calculate the dose for a 50 kg adult who require a 40% correction. That is, you are planning to maintain a level of 40 international units per deciliter. So for this patient, the formula will be 50 kg into 40 into 0.5. That is, you have to use 1000 international units of factor 8. And this dose has to be given 12th hourly. So the formula is to calculate the one-time dose, and the dose has to be repeated 12th hourly for adequate factor level in case of factor 8. And the factor 8 infusion should be infused as a, you can use it as a direct IV infusion over given slowly over 3 minutes. Usually in our routine clinical practice, we do not assess the factor level. After giving the infusion, you will assess the clinical improvement of the patient. We do not assess the peak factor level after infusing it. But in certain rare situations, like patient is proceeding with a surgery, in such cases, it is better that you assess the factor recovery by assessing the peak factor level 15 to 30 minutes after infusion. Usually, we do not routinely monitor the factor levels routinely during therapy. But in situations like when the patient is undergoing surgery, or in situations where when we are adequately treating the patient, but there is no clinical response, in such situation, you can proceed with the factor assay to see whether there is adequate recovery of the factor. Now coming to factor 9 concentrates. Factor 9 concentrates are categorized into two classes. One is pure factor 9 concentrates, which contain factor 9 alone. Next is APCC, or activated prothrombin complex concentrates, which contain, apart from factor 9, you have prothrombin, factor 7 and factor 10. So FABA is an example of PCC containing factor 9. Then you have the recombinant factor 9. So factor 9 concentrates are available in strengths like 600 IU, 1200 international units, etc. And each international units of recombinant or standard half-life factor 9 per kg of body weight, if infused intravenously, it will increase the plasma factor 9 level by 1 unit per deciliter. And based on this, we put the formula as body weight into desired factor level for calculating the factor 9 dose. And the half-life of factor 9 is approximately 18 to 24 hours. Hence, it can be given as once daily dosing. So this is an example for a 50 kg patient. If we want to raise the factor level to 40%, you can just multiply 50 into 40, that is 2000 international units of factor 9 has to be infused once daily. As in case of factor 8, you routinely do not monitor the factor levels, but in cases of surgery and if there is a suspected non-response to factor therapy, you should do the factor level and assess the factor recovery. And one peculiarity of factor 9 is that this factor 9 concentrates can cause allergic reactions. And this allergic, usually factor 8 infusions will not cause any allergic reactions. But in cases where factor 9 patient with inhibitor, they can develop allergic reactions to factor 9 treatment. This is very rare, can occur only in 2 to 4% of cases. Now, management of specific hemorrhages. Now, coming to joint hemorrhage, which is the 80% cases, patient will be present with a joint hemorrhage. So, before developing a hemorrhage, patient can have a sensation of tightness or tingling within the joint, which is we call as aura. This is followed by increasing swelling and warmth of the joint and serially increasing pain of the joint. And there will be a loss of range of motion, or there is a joint will be totally patient will keep it in an immobilized manner because of the pain. That is, the range of motion is completely lost. So that is how you identify a joint hemorrhage or acute hemarthrosis. So when such patient comes, before giving factor 8, first we have to give the first aid. The mnemonic is PRICE. P stands for joint protection or protection of the injured area. R stands for rest. Ice is ice application. Then C is compression and E is elevation. You should always rest in the most comfortable or relaxed position for that joint. For example, for knee joint, it will be the flexed position. So you can keep 1 or 2 pillows below the knee joint and keep it elevated. And ice, you have to keep it wrapped in a cloth. Then you have to place a towel or any other cloth over the joint and keep this wrapped ice over the joint, and it can be kept for some 3 to 5 minutes, then remove. And again, after some time, you can keep, it will promote vasoconstriction. Then you can use the compression bandage. Compression bandage will be available with most of the patients, or they have to buy. Whenever there is a bleeding, they can keep it, the compression bandage can be wrapped around the joint. This will decrease the joint space and prevent further bleeding. And limb should be kept in elevation. Then for elbow joint, it will be you can see, give a sling around the neck to keep it immobilized. So these are the first aid which we can give. And severe hemarthrosis should be treated immediately with the intravenous clotting factor replacement. And how much dose and how much duration we should, that is the most important question. For severe hemarthrosis, ideal is that you should treat for 1 to 2 days. And adequate dose, that is 10 to 20% correction, is that is recommended by the WFH low dose practice pattern. But for very mild bleed, if the clinical symptoms are of only mild or moderate severity, you can give 1 dose of factor and then assess the patient after 8 hours or 12 hours. Then if the symptoms are persisting, you can give a second dose. So these patients with 1 dose, they can go home and then report back if there is a further increase in symptoms. But severe bleeds, it is ideal that patient should get admitted so that you can reassess them every 12th hour. Now, this is the WFH practice pattern, a low dose practice pattern. You can see that for a joint bleed, they recommend 10 to 20% correction, and this has to be maintained for 1 to 2 days, depending upon the severity. What we can do is we can take a printout of this and keep in our casualties to so that whenever patient can come, we can just refer to this dose and then give it accordingly. Now, there is a correct method to assess the clinical response also. According to it, the response has been graded as excellent, good, moderate, or no response. If there is an excellent response, there will be a complete pain relief and complete resolution of all the symptoms of a joint bleed within 8 hours of infusion. And the patient will not require any further dose in the next subsequent 2 to 3 days for their joint bleed. So that is excellent response to factor therapy. And if it is a good response, the patient will have significant pain relief. It is not a complete relief, but there is a significant reduction in the next 8 hours. But the patient will require more than 1 infusion in the subsequent 1 to 2 days for their complete resolution. If there is a moderate response, patient will have a modest improvement in their pain, but patient will need further doses within the next 1 to 2 days for the complete resolution of symptoms. And if some patients will not have any improvement at all, even with the adequate factor dose, in such cases, you should suspect whether there is any fracture or if the patient is developing any inhibitor and had become a non-responder to therapy. So that is the assessment of bleed after giving adequate therapy. So our assessment should be very important, because if we don't do the assessment correctly, we will be again giving factor, and we will be overusing the factor. Another point of important at this point of time is, apart from the physiotherapy, first aid, that is price, and factor therapy, we should give them adequate analgesics. That will come with that will deal with later. Adequate analgesia is very important, because if we do not give analgesics, again some amount of pain will persist, and we will start overusing factors. Now, what is a target joint? A target joint is a single joint in which you get 3 or more spontaneous bleeds within a consecutive 6-month period. So that is what we call a target joint. Now, one important question is whether to do a joint aspiration. In most of the situations, we will never do a joint aspiration in the case of hemophilia, but in some rare occasions, like if we are suspecting a septic arthritis, patient has severe fever and present similar to what is acute hemarthrosis, or the patient, despite our factor therapy, patient has a very painful tense joint. In such situations, sometimes we might have to attempt a joint aspiration. In such cases, always raise the factor level by 30 to 50 international units per deciliter for joint aspiration, and the same level has to be maintained for 2 to 3 hours. Now, the next important bleed is the central nervous system or intracranial hemorrhage. In a case with hemophilia, all the head injuries, all headaches, which lasting for several hours, or any drowsiness, should be treated as an IC bleed. So before proceeding with CT brain, you should always give the first dose of factor from casualty, then only send the patient for CT brain. So immediate treatment with the clotting factor is the most important factor. And for case of intracranial hemorrhage, the patient has to be treated for 10 to 14 days. And whenever a child develops intracranial hemorrhage, or even an adult, this is one indication that there is a chance of recurrence also, and this patient can be kept on a short-term prophylaxis or otherwise the tertiary prophylaxis for the subsequent 3 to 6 months. So this is the dose for intracranial hemorrhage. From this, you can see that intracranial hemorrhage, the initial dose will be low dose practice pattern, 50 to 80% for first 1 to 3 days. But in the case of serious bleeds like intracranial hemorrhage and surgeries, we usually give the first day, we will give the high dose practice pattern. That is the usually 100% will be maintained. For all other instances, we will follow the low dose practice pattern. But for IC bleed and for surgery, we usually use the high dose practice. So initial dose will be 50 to 80% for 1 to 3 days. Maintenance dose will be 20 to 40% for 8 to 14 days and 30 to 50% for subsequent 4 to 7 days. So the total duration of therapy will be approximately 14 to 21 days. And based on our clinical assessment of the patient, we can either increase or decrease the dose. Now coming to hematoma. Always the first aid include immobilization, application of firm pressure and ice, which will help in some hemostasis. Now, hematomas can be small or it can be very big, big enough to cause a compartment syndrome, which can occur in retroperitoneal space, scrotum, buttocks, thighs. You can have very large hematomas, resulting in large amount of blood loss. So most important thing is start factor therapy at the earliest possible. And if it is a big hematoma, always monitor heart rate, BP, and hemoglobin to assess whether there is a significant blood loss. So for small hematomas, superficial hematomas, you can give 10 to 20% correction for 2 to 3 days. For bigger bleeds like psoas hematoma and other bigger vastus hematomas, thigh hematomas, you can use a higher dose like 20 to 40% for the initial 1 to 2 days and a maintenance dose of 10 to 20% for the subsequent 3 to 5 days. So the total duration of therapy for a psoas or a bigger hematoma will be at least 5 days. And if there is no clinical resolution, you can extend it up to 6th or 7th day. Now coming to the mucosal bleed, can occur from various sites. Throat and neck hemorrhage should be immediately treated because it is a life-threatening bleed. It can cause compression of the trachea and patient always needs hospitalization. Apart from minor hemarthrosis, most of the other situations, ideal is that patient should be hospitalized. Now, gastrointestinal bleeding also very dangerous because patients have previously presented in shock, unrecordable BP, and very low hemoglobin as low as 2 gram per deciliter due to gastrointestinal bleeding. So all GI bleeds, it is very life-threatening. We have to admit the patient always and immediately raise the fat level to the desired level as in the low-dose practice pattern. And the duration also is slightly longer, and always monitor the vital signs and hemoglobin and transfuse the patient. Apart from our factor therapy, you should give blood transfusion to correct the hemoglobin to a target of at least 10. Renal bleed or hematuria. Hematuria is also should be treated as a serious bleed, and mild painless hematuria. These patients can take complete bed rest at home, and they can be advised vigorous hydration of 3 liter per meter square. Such amount of fluid should be taken, and they have to take bed rest until the bleeding stops. One thing regarding renal bleeds is that you should never give tranexamic acid or other antifibrinolytic agents because it can promote a clot colic. And clotting factor replacement should be given till the bleeding is resolved. For all the hematuria which is not resolving with the above mentioned measures, you give a clotting factor replacement till the bleeding is resolved. So for the hemostatic level for all these bleeds, like throat and neck hemorrhage, initial level of 30 to 50% for 1 to 3 days, and maintenance dose of 10 to 20% for subsequent 4 to 7 days. For gastrointestinal bleed, again, same dose can be used, 30 to 50 for 1 to 3 days, followed by 10 to 20% for 4 to 7 days. And renal bleed, you have to give 20 to 40. If it is a significant bleed, you have to give 20 to 40% correction for 3 to 5 days. And sometimes patient can have injuries with a knife, etc. Then they can come with a laceration. And most important point, you should never attempt suturing without giving factor, because you can never complete the procedure without giving the factor, because patient will be continuously bleeding and you will start suturing from one side and it will end up in a big hematoma and swelling. So always give the first dose of factor at 40% correction, then only attempt suturing if it is a laceration. Now oral bleeds. Oral bleeds can occur as a spontaneous gum bleed, or it can follow a dental extraction or trauma. And always, you need not give factor for all the oral bleeds. If it is a small bleed, you can apply direct pressure over the bleeding site with a gauze. Or if you have removed some decidual tooth which have fallen down, you can apply direct pressure over the tooth socket using a damp gauze, which is dipped in antifibrinolytic agents. Either you can use an IV tranexamic acid vial, you can break it and take out the tranexamic acid, and the gauze can be dipped in that. Or at home, what we can do is we can powder the tranexamic acid tablet, crush it, dissolve it in water, make it into a solution, and dip the gauze in the tranexamic acid and place it over the bleeding site. And if it is, and you can use the gauze which is dipped in ice cold water also. And if the bleeding is not subsiding with these measures, you can proceed with the factor therapy. And if the bleeding persists for more than 6 hours in case of oral bleeds, always go for clotting factor therapy. And other topical agents like adrenaline, etc., also can be used. Coming to epistaxis. Epistaxis, you should always keep the patient seated, head and elevated, keep it in the forward position. And you can apply cold compression to little's area in a gauze which is soaked in ice water for 5 to 10 minutes. Usually try to avoid nasal packing, because once you remove the pack, again patient can rebleed. And so tight nasal packing, ideally it should be avoided. And you can use this gauze which is soaked in either ice or antifibrinolytic agents like tranexamic acid. Then you can use antihistamine, decongestant medications, and nasal spray can be used. And if the bleeding is not subsiding with all these first aid measures, you can give clotting factor therapy. Now, coming to surgery and invasive procedures should always be undertaken in those institutions in which there is adequate support from all the other departments. That is, you have to have factor assays as and when available. You have to have a good blood bank to give blood products if there is a significant blood loss. Then you should have a good team of doctors who are involved in that surgery. So inhibitor screening should be mandatory before all the surgeries. And mild hemophilic patients like mild hemophilia and von Willebrand's type 1 disease, that is mild von Willebrand's disease, these patients can undergo minor procedures under DDAVP cover. You can use desmopressin as a nasal spray or an IV infusion. But this will not raise the factor level beyond 20 to 30%. So only in case of mild hemophilia or a mild von Willebrand, you can attempt a minor procedure with the DDAVP cover. And whenever we are using surgery, we are using very high dose for a prolonged period. And all these patients should subsequently get screened for inhibitor development. So as you can see in the bottom, surgery for a major surgery, pre-op, we are usually for all major surgeries, we follow the high dose practice pattern. That is, we will give 100% at least correction for at least the day 1 and mostly day 2 also. Then only we will shift to the low dose practice pattern. So that depending upon ideally the pattern recovery or pattern level should be assessed, and then our pattern therapy should be guided by the clinical response of the patient and the pattern recovery levels. So before any other invasive diagnostic procedures like ABG, or you are doing a endoscopic procedure or any intravascular procedures, all these procedures when done in hemophilic patients should be done under clotting factor cover. Now another special situation is circumcision. For circumcision, plasma factor level has to be raised to 80 to 100% just prior to the procedures. And post-procedure also, we have to maintain a factor level 50 units per deciliter for first 3 days and at least 30 units per deciliter for subsequent 4 to 8 days. And other trophical fibrin glue, CLNs, etc. can be used for hemostasis. Many of these hemophilic patients, mothers or sisters will be going for delivery or cesarean section. So their fat level should be screened because they also will be having borderline low levels, and our target is to maintain a level of at least 50% for labor and delivery, and this level should be maintained for at least 3 days following vaginal delivery or 5 days following a cesarean section. Now the next most common doubt the patients will be having is regarding vaccination. All these patients should be children, especially children, should be given all the vaccines, and most of these vaccines can be given subcutaneously. And if one vaccine can be given only by IM intravascular route, you can still give the vaccine. But prior to giving the vaccine, you can administer 1 dose of factor to maintain the factor level more than 10%. So we can calculate according to the body weight, and you can give attempt to maintain the fat level above 10%, and this dose has to be taken on the morning, and subsequently patient can be vaccinated even with an intramuscular vaccine. That is most important now in regarding the COVID vaccine, which can be given only intramuscular. So whenever there is a severe hemophilia, we will advise them to take 1 clotting factor concentrate and then subsequently take the vaccine. And for this, the ideal needle size will be 25 to 27 gauge needle should be used for IM injection, and we should apply pressure to the vaccine site at least for 10 minutes after giving the vaccination to prevent any bleeding or swelling. And you can give ice packing also. Now coming to the pain management, this is very important because in all the acute hemarthrosis, we should give adequate analgesia. So for that, ideally we can use paracetamol and 3 to 4 times per day, or tramadol 3 times per day. And we can use coxins. Among the NSAIDs, we can use coxins inhibitors like celecoxib, and other analgesics are not recommended. And if there is no pain relief, you can give morphine also. So this is regarding the clotting factor concentrates. So the other adjunctive therapy, one is the antifibrinolytic agent, then desmopressin, then other agents like bypassing agents, then extended half-life products. So DDAVP or desmopressin, this acts by increasing the release of factor from the storage sites. So factor 8 and von Willebrand factor both are stored in the endothelium. So we have some amount of stores, especially in patients with mild hemophilia, and even some in moderate hemophilia also. But in severe hemophilia, you have absolutely no stores. So DDAVP should not be given for severe hemophilia for hemostasis. And you can see that factor level beyond 20 to 30% can, beyond that we will not get any higher levels. So ideal indication for DDAVP is you can use it for mild hemophiliacs or mild von Willebrand's disease. If you are planning minor procedure, you can give it as a nasal spray or a IV infusion, single IV dose of 0.3 microgram per kg. Infused in 100 ml over 30 minutes, and this has to be given 60 minutes or 1 hour prior to the procedure. And you cannot use it beyond 48 hours because the patient will develop tachyphylaxis and they will become a non-responder. A nasal spray, we can use a nasal spray of strength 300 microgram for more than 50 kg and 150 microgram for less than 50 kg, and you can give 1 puff to each nostril 30 minutes to 1 hour prior to minor procedures like dental extraction for mild hemophilia. So desmopressin is indicated in mild to moderate hemophilia for females carriers of hemophilia, then mild von Willebrand's, and also in some rare situations like CKD, liver disease, platelet dysfunctions. These conditions can cause platelet dysfunction. So for them, if they are planning any minor procedure, in that situation also you can use desmopressin. And it should not be used in children less than 2 years. And it is never used for severe hemophiliacs. Now, antifibrinolytic agents which can be used are tranexamic acid. For all the mucosal bleeds and all the dental procedures should be covered with antifibrinolytic agents like Tranexa, contraindicated only in case of a if you are dealing with a hematuria. And also when we are using this in adjunct with the products like APCC or FIBA, you should, along with the FIBA, you should not use tranexamic acid. So the dose of oral tablets will be 25 mg per kg 3 to 4 times daily, or IV infusion 10 mg per kg 2 to 3 times daily. And this is especially helpful in case of dental extraction and of all the mucosal bleeds. For dental extraction, you can prescribe this on the morning, Tranexa to be taken on the morning of the procedure, and subsequently for 3 to 5 days, depending upon the achievement of hemostasis. Sometimes even without factor cover also, this is possible while by giving Tranexa. But in our clinical practice for dental extraction, we always give at least one dose of factor concentrate prior to the procedure, and subsequent bleeding can be well controlled with giving oral tranexamic acid. If it is a one single tooth extraction, suppose a patient requires more than 2 tooth extraction at the same time, then it is ideal that patient be admitted, then give factor concentrate in the morning, do the procedure, and again continue admission, so that sometimes the patient may need factor product in the evening also and next day also, if it is a more than 2 to 3 tooth extraction done simultaneously. Now coming to EHL Factor products, that is extended half-life products, that is we are modifying the product in some way, like FC fusion or some B domain deletion. So if such genetically modified or engineered factor, if we are using, the half-life will be prolonged by approximately 1.4 to 1.6 folds, so that we can give the same product in like 2 doses per week, etc. will be sufficient. And in case of factor 9, even once per 2 weeks, that dose also is sufficient if we are using an EHL product. Eloctate is an example of a EHL factor product. Now coming to the bypassing agents, these are usually used for treatment of patients with factor 7 inhibitors or factor 8 inhibitor or factor 9 inhibitors. So as we already told, there are 2 products, recombinant factor 7A and APCC or prothrombin complex concentrate. The example will be FIBA or factor 8 inhibitor bypass activity. And for factor 8 inhibitor, either of these products can be used, either FIBA or Novo 7 or activated factor 7 can be used, and efficacy is almost similar, but according to certain unknown factors, some patients will most of the patients will respond to FIBA, but some patients will lose their response to FIBA and they have to be treated with factor 7, and some patients will never respond to FIBA, they will always need factor 7 for their therapy. And but patients with factor 9 inhibitors cannot be given FIBA because FIBA will contain factor 9. So factor 9 inhibitor patients will always need activated factor 7 for their therapy. So WFH recommends that patients with hemophilia with inhibitor should be considered with regular prophylaxis with any of these products to prevent bleeding manifestations. FIBA prophylaxis, etc. is there. So recombinant factor 7A. So this is the product. It is available in various strength like 1 mg, 2 mg, etc. So it binds to tissue factor to activate factor 10 and factor 9 and allows coagulation cascade to continue even in the absence of factor 8 or factor 9 or in the presence of inhibitor to factor 8 or factor 9. Now APCC contains factor 2 or prothrombin, factor 9, factor 10 and factor 7. So for patients with hemophilia B and an inhibitor with a history of anaphylaxis to factor 9 containing clotic factor, we should suspect inhibitor. In such patients, subsequently can use only recombinant factor 7A to treat their bleeds. Now, so we have, and regarding FIBA and Novo or activated factor 7, we have covered in the previous session. And each of these products have unique way of administration, which is usually given in their package insert. Usually factor 8 and factor 9 is available as powdered form with the diluent also comes with the package, and you can dilute the powder in the same diluent and then take it as an IV infusion. Usual volume of these products will be 10 ml. So it can be drawn in a 10 ml syringe and given as a slow IV infusion over 3 minutes. And regarding Novo 7, the package insert gives the technique to be followed in the administration of the thing. And regarding FIBA or APCC, it has to be given as an infusion in 100 ml normal saline. And again, 12th hourly dosing will be followed for FIBA. And the usual dose is 50 to 100 units per kg. And you should never cross the ceiling dose is there. Ceiling dose is 200 units per kg. Beyond that, if you dose is used beyond 200 units per kg per day, the chance is that the patient can develop a significant or a serious thrombotic event. So that is one warning for using recombinant factor 7A and APCC. The patient is at a risk of developing thrombotic event, although the chance is only remote, that is 2% cases. And when none of these products are available, whatever we can use is our time-tested old blood products like FFP. 1 ml of FFP will contain 1 unit factor. So you cannot achieve a factor level more than 30% by giving FFP. The dose will be 15 to 20 ml per kg. Cryoprecipitate again. Cryoprecipitate has factor 8, 1 milligrams factor, fibrinogen, and factor 13. But cryo doesn't contain factor 9. So cryoprecipitate also can be used if the routine factor concentrates are not available. So cryo can be used for the treatment of hemophilia A alone. You cannot use it for hemophilia B. But FFP can be given for either of these. Now, inhibitors in hemophilia. Presence of inhibitors, inhibitor is defined. In case of factor 8, any Bethesda titer of more than 0.6 Bethesda units is defined as a positive inhibitor. And for factor 9, any value more than 0.3 Bethesda units is defined as a positive inhibitor. Now, if the value is less than 5 Bethesda units, you will call it as a low responding inhibitor. If it is more than 5 Bethesda units, you will call it as a high responding inhibitor. So management of bleeding in an inhibitor is with a bypassing agent. And the next is removal of the inhibitor. That is, you can remove the antibody as such using immunosuppressive therapy. That is the immune tolerance induction. So the choice of treatment of an inhibitor patient will be depending upon the titer of inhibitor, the records of the previous clinical response to the product, then the site of bleed and the severity of bleed. So for hemophilia A, you can use for low responding inhibitor. There is a chance that you can still use factor 7 at high doses. But for a high responding inhibitor, that is more than 5 Bethesda units, you have to use a recombinant factor 7A or a prothrombin complex concentrate. And factor 9, that is hemophilia B. For low responding inhibitor, you can use factor 9 at a higher dose. For high responding inhibitor, you have to use activated factor 7A. So this we have discussed in the previous class also, that is recombinant factor 7A. The mechanism, it directly activates the tissue factor. The disadvantage is the half-life is very short, only 2 to 3 hours, and the cost is also very high. And the infusion volume, it's already comes as a infusion. This product already comes as a small vial, and the infusion technique is already shown with the package insert. And the dose will be 90 to 120 microgram per kg, which has to be repeated every 3 to 4 hours. Or you can use a bolus dose of 270 microgram per kg in adults or 180 microgram per kg in children. And efficacy is almost 80% for clinical improvement of any bleed. And it can be used for prophylaxis also. Regarding APCC, the contents are factor 2, factor 9, factor 7, and factor 10. And the half-life is 8 to 12 hours. So you can use it as a twice daily dosing. You can reconstitute the powder diluent and it can be infused in 100 ml NS. The dose is 50 to 100 units per kg 12th hourly. So you should not increase the dose beyond 200 units per day. And efficacy is similar. Both are equally efficacious, 80% efficacy. And for prophylaxis, it is used at a dose of 85 units per kg every three times per week. So that is regarding the treatment of various bleeding manifestations in hemophilia. We will end up with this session.